Hi everyone, welcome to another Friday section. We are really excited to have you all here with us. It will be probably a great episode and discussion. And I want to tell a little bit what we're gonna have tomorrow. Tomorrow we're gonna have at 1 p.m. AST our mat celebration. So if anyone here it's new in the mat and matted somewhere, come and celebrate with us. We want to hear histories and talk about it. Will be a great episode. And then after that, we are gonna have Yusuf that will start a new format talking about the management reasoning. We will talk about the treatment and a management and a disease. So it's something new that we are starting tomorrow, and we are really excited about it. So yeah, I will pass the mic for Ravi. And how are you doing, my friend?
Thank you, Deborah. We're so excited for this. And I think if you're an IMG International Medical graduate listening on YouTube, I think this tomorrow is a great time to join us live and learn from Marcella and Rafa's journey. And I think that will be very, very special. It's also really cool today because we just learned that Bia, one of our newest team members, just got her first author publication. She put the link in the chat, so please check it out. We're thrilled to have you. And the good news from Europe doesn't end there, because we have two new friends who emailed the CP solvers and told us that they have a case for us. So this is the first time that we're meeting Mohammed and Sohail. Hello, and Nar. And I just saw that Prof Rez is here, so the party is going to get started. So before we hear magic and poetry, Mohammed and Sohail, do you want to unmute and say hello and introduce yourselves?
Yeah, sure. Yeah, so my name is Mohammed. I'm a third-year resident here. The residency of internal medicine is 5 years, so I'm a third-year internal medicine resident. And me and Sohail, we work in the same hospital trust.
Yes, and I'm Sohail Hutak, also internal medicine resident, and I've been following CP solvers. Both Rabi and Reza, learned a lot from you guys. Thank you so much.
Mohammed and Sohail, I know Prof Rez has many questions for you. I'll pass the mic to him, but wanted to welcome you. Just tell us where you're from. Where are you calling from?
Yeah, I mean, we work in Malmo, Sweden. So it's the southern part of Sweden. Yes, it's called the Malmo University Hospital, and yeah, that's where we work.
Guys, I am so excited. Thank you for joining us. What time is it there?
It's 5:10 p.m.
You finished the work for the day?
Yes, that's true.
Incredible. Well, very excited for
Thanks.
the case. And maybe we can put the whiteboard up, and whenever Mohammed and Sohail, you're ready, please present.
Yeah, okay. Yeah, sure. So our case, I think Sohail will take the initial part.
Yes. Okay, so we have a 32 years old male with elevated creatinine and tiredness. Should we stop there and continue?
Totally up to you, Sohail. You've seen this so many times. Whenever you stop, we'll start speaking. You let me know.
Okay, we can stop there. It's always interesting to
Awesome.
see.
So maybe I'll make just a few comments right here, and then see if Robbie has anything to add, but we can get more data. You know, it's so interesting. 32-year-old male. That's 6 years. Actually, yeah, 6 years younger than Prof Rez. Sometimes I don't remember how old I am, 37, 38. But this is a young person. And generally, young people are healthy. Now, we don't know the past medical history, which may influence the way we think about this patient. But if a young patient is coming for care with fatigue, you have to better believe that there's something sinister going on. And young people, One of my mentors used to say, which I usually don't say this because I don't think it's politically correct, but I'm going to say it nevertheless. Hey, Robbie, you remember Harry Hollander? He would say, with a young person, always think sex, drugs, and rock and roll, meaning that young people are at risk of, everyone is, but particularly young people, using substances, being in some kind of activities that put them at increased risk. Of course, this is without judgment. We say sex, drug, and rock and roll. The other thing that young people are at risk of are genetic syndromes, like hereditary conditions that may manifest in the 20s and early 30s. All that being said, I put the tiredness aside because tiredness is non-specific, very non-specific, and I focus on the kidney. And so then the kidney becomes an exercise of pre-renal, renal, or post-renal. Usually post-renal in a guy is due to prostate enlargement, but this patient is far too young for that. So if this is post-renal, you have to be open to other processes that may be influencing the nervous system. But ultimately, to go on this journey of kidney injury, we need more history, we'll need a urinalysis, and we'll need a physical exam.
Yes, so we should continue then. Great discussion so far. Yes, so the previous medical history, patient presented December 2022 with pancreatitis, and he was planned for MRCP follow-up March 2023. Because this pancreatitis, it was unknown etiology. And also to add the IgG level and everything, all the investigation was normal at this moment. We had also bilateral anterior uveitis diagnosed early February 2023, treated with steroid eye drops, responded well to that, and he had some renal stones at age 23, some atopic dermatitis treated with local steroid also. And should we continue now?
Oh my
Yes.
gosh, I'm so intrigued, but maybe you can round out just this bottom corner of medications, family history, social history, just to give us the full context for this presentation, and then we'll discuss.
Yes, sir. So family history, no autoimmune conditions from mother or father's side. Social history is Portuguese origin. No high-risk behavior reported. Works as barista job. A barista job involved lifting and standing a long time. Separated 6 months ago from a long-term relationship, heterosexual. And sporadic cigarette smoking and vapes daily, and that's it.
Amazing.
No known allergies. So, yes.
Awesome. Thank you so much. So of course now we have to stick to our original schema, which is sex, drugs, and rock and roll, and try to I can't believe you said that out loud, but I'm not the least bit surprised. And I think it's, I think politically correct is a great concept, but it's true. I think you really have to worry about those things. But now I think that we found that this past medical history is very, very unusual. And I think that automatically we realize that this is not your regular old 32-year-old young person, that he has so many background conditions. And Prophet, I think there's so much to dissect here. Maybe I can just take on the first thing, which is pancreatitis, and I'll leave the uveitis and other stuff to you to see how you can connect the dots. But it's tempting not to think that the dots are connected because of the rarity of all these things. And I think as a general approach to pancreatitis, you can look at on UpToDate or other resources and find a comprehensive list of diagnoses. However, there is a beautiful simplicity in pancreatitis because it usually is actually one of two things: alcohol and gallstones. That beautiful simplicity of alcohol and gallstones, it also shows you that it's actually often one of two categories, not just one of two things. And the two categories are either there's a specific substance that's causing the pancreatitis, alcohol, triglycerides, and medications, like a specific molecule, ETOH, TG, or med, or obstruction, the obstruction is usually gallstones, but actually can be any obstruction, as rare as mass-forming IgG4 disease, which our friends were alluding to by the IgG4 level, or as common as the unfortunate development of pancreatic cancer causing pancreatitis. So if you're trying to understand pancreatitis, simply think what substance and what obstruction. But if you want to apply base rate, the substance is alcohol and the obstruction is gallstones. And so here, we don't see any evidence of alcohol use in the health-related behavior. So we're like, hold on, wow. And then you don't see any reason to suspect gallstones because this is a 32-year-old man and he does not appear to have a history of intermittent biliary colic. So automatically, you're moving to tier 2 of the pancreatitis world, which if you didn't suspect already, based on the other data, the creatinine and the uveitis, I think that those things tell you you're probably dealing with pancreatic esoteria. All right, Prof. Raz, mic to you.
I absolutely love that, Robbie. And I think that when you're layering on this sort of pancreatitis to the kidney injury, oftentimes we think of kidney injury probably in majority of patients as being pre-renal in etiology, meaning that the patient is volume down. In the hospital, 80% of it is going to be due to sepsis. Like, 80%, just the majority is due to sepsis. But Robbie makes a very compelling argument that in this patient with kidney injury, with the background of pancreatitis and uveitis, you really have to prioritize an intrinsic cause of kidney injury and see how can you explain all three of these findings with a single diagnosis. So you may be asking, which one of these findings should you focus on of the three? Actually, this isn't a rhetorical question. Let me ask the audience, put it in the chat. Of kidney injury, pancreatitis, and uveitis, if we were thinking purely in diagnostic reasoning, which one of these three findings should be prioritized and serve as your anchor, with the other ones being in the background that you use to help prioritize amongst your anchor? Really, the one that's most unique here is the uveitis. Remember, kidney injury oftentimes is a bystander, and we have to be open to that possibility here as well. So it's not the most fruitful use of our time. The other thing that's helpful, though, is what if Mohammed and Sohail tell us that the creatinine is 12? Well, that severity may change what I prioritize. But Robbie, what's so interesting, many times what we prioritize as diagnosticians is not only what's so unique and carries the most limited differential diagnosis, it's also what are we most comfortable with. I think every one of us wants to run towards the kidney injury because we've been taught an approach since a young age. But the uveitis, you can't shy away from it and you have to lean into it. And with uveitis, the way to approach it is as follows. It does help to categorize it as sort of anterior, posterior, or pan-uveitis. This is really helpful. I will say, take this with a grain of salt. Remember, this is just one compartment. Like you're looking at the uvea, you're saying, are you anterior to the uvea? Are you posterior? Are you the entire uvea? And it's often easy to miss posterior uveitis because the findings sort of hide from the clinician's eye, while anterior uveitis is staring the clinician directly in the face. But remember, any process can affect any part of the uvea, though there's some processes, for example, Behçet's. Behçet's is a disease that causes panuveitis, and it can be extremely aggressive in both eyes. What I use as a memory aid, and correct me if I'm wrong, Robbie, is when I think of anterior uveitis, it makes me think of ankylosing spondylitis, and then that puts me in the autoimmune category of all the spondyloarthropathies and other autoimmune processes from lupus, Sjogren's, sarcoid, in addition to the spondyloarthropathies. And now that I think of it, a lot of them have S's in front of them. Then there's stuff like inflammatory bowel disease that can also present with anterior uveitis. The posterior uveitis, that's when I think more infectious etiologies, and those can be stuff from viruses like CMV and many other infectious etiologies. But we look at the host, he's 32, we need an HIV test because HIV could cause nephropathy, it could cause pancreatitis, and it can cause uveitis. But the uveitis being anterior with this patient's age really prioritizes an autoimmune process. And when we think of autoimmune pancreatitis, we often think of IgG4 related disease, but really anything that involves the vessels, like if you have ischemia to the pancreas, you're going to develop pancreatitis. And if I step back for 1 second and you ask the question, why do people actually develop pancreatitis? Like, what is the core of pancreatitis? It's the activation of enzymes that are involved in digestion of fat prematurely. And the main enzyme we think about is trypsinogen. So when you have a stone, you get high pressures in the duct. These cause the acinar cells of the pancreas, which are the primary exocrine cells that secrete the enzymes, to activate the enzyme prematurely. And now you start degrading the pancreas. But if you have ischemia to the pancreas, you still get premature activation. So, Robs, I would love to pass it back to you for a second. I'm getting the flavor of autoimmune. I definitely want an HIV test, but the way I can link everything together, and it's a tough one because it seems like everything's not happening at once, but they're happening, at separate time points. So you have to be open with them being unrelated. But if we were really to link them together, if you have an autoimmune process that's causing anterior uveitis, that's causing, for example, interstitial nephritis or glomerular nephritis, that's causing some kind of local vascular insufficiency of the pancreas, you may be able to explain all three findings. This is a reach for sure.
No, 100%, Prof. Rez, and I think you should probably, like, all of us should practice our reaches in these cases. That's the point of these VMRs. But also, like, I think that whatever this diagnosis is going to be a reach, like kidney injury. A 32-year-old is having this many medical history. Come on, you're 38 and you're as healthy as anybody else, right? So, I don't have anything to add to that, and I'm just open to the possibility that the kidney stones may be progressively causing the kidney dysfunction as another non-specific bystander. And anytime you have GI malabsorption in the pancreas and kidney stones, you have to think of that the kidney stones are completely a byproduct of malabsorption through oxalosis. When your GI tract doesn't work, you malabsorb calcium. That calcium chelates. When you I'll walk through that reasoning again one more time. You malabsorb fat. The fat chelates calcium, and the calcium no longer chelates oxalate. So oxalate is free to diffuse into the body, and it causes kidney stones. So that's one way you can link it by a less sort of elegant mechanism. I'm actually, Prof. Rez, also intrigued by the atopic dermatitis, because if we phrase this as an allergic type autoimmune disease, I think that re-puts IgG4 disease back into the equation, because you might have heard, hey, this patient has mysterious pancreatitis, but the IgG4 level is normal. But you have to be careful. The sensitivity of IgG4 level and IgG4 disease is only about 80%. And IgG4 disease is unique in its ability to cause atopy or atopic reactions. So here, I completely agree with what you're saying. I think this is autoimmune in nature. And if you look at this, I think the most elegant answer would be what causes uveitis, pancreatitis, kidney injury, and atopic dermatitis, and it's IgG4 disease. But the IgG4 level will make you should make you walk away from it, but not run away from it. Yeah, autoimmune it is. We'll see how wrong we are if the HIV test is positive, but I'm feeling the same vibes. All right, folks, tell us more, please.
Yeah, so we can, do you want to know more about the history of presenting illness or more of the exam? What do you want to know more about? Yeah.
Well, we'll dance with you wherever you want to go.
Yeah, okay, let's take some more history of presenting illness. So I met this patient in the outpatient nephrology clinic while I was doing my rotation, and I kind of had similar thoughts. Is that IgG4, is that sarcoidosis, is that TINU, tubular interstitial nephropathy with uveitis? But yeah, so the patient, he has been feeling under the weather for the past 4 to 6 weeks. He said that he's been tired mainly at the end of the day, given that he has a very demanding job requiring lifting and so on. He has felt that his clothes have been a bit looser. However, he's not measured his weight. He reports that his appetite was unchanged along with his amount of urine. He doesn't report any foamy urine, His urinary color has been unchanged. He did not pass any stones or any macrohematuria. After the pancreatitis, which occurred December 2022, he felt increasingly bloated postprandially. He did not take any NSAIDs and did not use any over-the-counter supplements. He doesn't report any muscle pain or any inflammatory joint pains, i.e. pains in the morning. He doesn't have that. His vision has become unhindered after treatment with the steroid drops, and his anterior uveitis was in good regression. He never experienced any fevers, but he did feel some night sweats. So yeah, do you want to know more about the exam maybe? Or
maybe
your
I can
analysis?
comment here, Mohammed, briefly,
Sure.
and then we can go to the exam for Robbie. But this is really interesting because you're painting a picture of a patient who has lost significant weight. And I think you taught us I've never actually thought about weight loss in terms of how is the clothes fitting, but now I'm going to use that. Mohammed, I like that. That's a good teaching pearl. So this patient has lost weight, and what weight loss means, and I'll be very specific here. If someone tells me they have a normal appetite and are eating normally and they lose weight, then I think about one of two possibilities. Either they have some kind of malabsorption, which would work well with Robbie's hypothesis of stone formation, kidney stone formation, or they have a hypermetabolic condition like thyrotoxicosis, diabetes, or FeO. Now, here's something I learned just last week on a Curbsiders podcast. Did you know that 30 to 40% of patients who have pancreatitis will go on to develop diabetes? Because the pancreas, there's two main complications that happen after you have an inflamed pancreas. One of them is diabetes, but the other is exocrine insufficiency. And it's not, 2% of patients. It's a big portion. It's a big portion. The data is true. So in follow-up, you actually got to check an A1C in these patients. So now if we say someone had acute pancreatitis, is coming in with weight loss, I would think, could they have had a complication of that pancreatitis leading to exocrine insufficiency? Or could they now have diabetes leading to gastroparesis and bloating? So you have to be very cautious with this additional data because it just might be ramifications of this guy's poor acute pancreatitis, or it may represent just inflammation, weight loss, and part of the prior diagnosis of anterior uveitis. We're ready for the exam, but to just quickly ground ourselves, I'll say this is a young individual with steroid responsive anterior uveitis and dermatitis, who's now presenting with renal insufficiency, weight loss, bloating after an episode of pancreatitis. I can't be more specific than that. I have to be open to all possibility complications of something that just occurred or something that's unrelated to what has occurred. Robbie is smiling, so let's see what is on his mind before we go to the exam.
Oh, I'm just impressed by the epic clinical reasoning, but the even better grammar. That was amazing.
You know why I did that, Robbie? Because in my French course right now, they're like reading something like "Vergul, what?" And they're saying,
Oh, Mohammed, so please keep us focused, please.
So his vitals, his heart rate was at 60 beats per minute regular, and his blood pressure was at 105 at the systolic. His SATs were normal. When like on inspection, he was slightly cachectic. He had very slight wasting of the temporal muscles. He had patches of atopic dermatitis on the right elbow, but otherwise his skin was normal. On abdominal exam, there were no masses and no pain. He did not have any succussion splash and no epigastric pain after his pancreatitis. He did not have any erythema or warmth in the small joints of the hands or on the wrist or on the knees. His nails looked normal with no pitting. His eyes had very slight residual redness in the conjunctiva at the junction with the iris. His vision was intact. His weight, we measured it at the OPD clinic, was at 62. His pancreatitis, which was diagnosed 4 months prior to the presentation, he was discharged with a weight of 71 kg, so he had lost 9 kg in weight. His urine dipstick showed the following. He had 2+. Do you call it 2 positive or 2+ in English, by the way? Yeah, 2+ protein, 1+ erythrocytes, 1+ leukocytes, and 1+ on glucose. His urinalysis, which we did at the bedside as well, showed 1 granular cast for every 2 high power fields on microscopy, and 1 waxy cylinder per high power field. We also did a post-voiding residual volume, and he had 100 milliliter after voiding, so it was normal. Yeah, do you want maybe more? Do you want some labs or?
Yeah, why don't we get some labs too?
Yeah, sure. So his creatinine, when he was referred, he had, we converted it to the American units. He had 2.9 milligrams per deciliter of creatinine, and at discharge, when he was discharged from the hospital 4 months ago, he had an entirely normal creatinine. His urea was at 10.3 millimolars. So we calculated a BUN to creatinine ratio of 9.9. His eGFR was at 26. His ESR, like the sedimentation rate, was at 104 with a CRP of 40. He had a slightly low hemoglobin at 111, so it's 11.1 in American units, I think, grams per deciliter. He has normal MCV and elevated platelets at 515. The basic metabolic panel, when it comes to calcium, was normal. The sodium was normal, and his serum glucose was also normal, along with LFTs. One interesting finding was that his prostate-specific antigen was at 11 in our units here, so it was slightly elevated. Do you want more information?
Well, I'm just amazed that you have prepared so much to convert the units into American units. That's very kind of you. Really, really appreciate it.
That's okay.
And I can also tell just how detail oriented you are and what data you're choosing to reveal over and over again. So I'll just share that I think the exam is actually very, very powerful because it paints a picture of somebody who is dwindling and not looking very healthy with the cachexia. I mean, seeing a 32-year-old look cachectic has got to be a jolt. And I think that pushes your foot on the gas to really get to the bottom of it. But I think there is a lot of clarity that is gained with looking at the labs. And for that, I'll pass the mic to Prof. Rez, and we can dance however you like, Prof. Rez, but I'll have you kick it off.
Sounds wonderful, Robbie. Mohammed, what did you say the creatinine was? I see we have a ratio there, but what was the creatinine?
Yeah, it was 2.9 milligrams per deciliter in American units.
And then, Mohammed, what was this creatinine, prior creatinine?
Yeah, I mean, in our units, we have the millimolar ones. It was 94, so it was 0.9 in American units, approximately.
I understand. Thank you so much. And maybe, Robbie, I can just focus on the Chem7 and the UA and leave the rest of the data for you to dissect. I think what's so fascinating here is, what did Mohammed tell us about this guy's muscle mass? What did he say? He said this patient is cachectic, has a low muscle mass. You know how we talked about creatinine? This creatinine of the current creatinine of like 2.1 or whatever, it's markedly abnormal in this patient, markedly abnormal. So this patient has acute kidney injury. And we have a prior creatinine that was normal, so we can say it's acute kidney injury. And whenever you don't know if it's acute or not, just always assume it's acute kidney injury. Never start with the chronic kidney disease. When you have acute kidney injury, I know the tendency is you want to look at this UA and be like, oh, there's 2+ protein. Could this person have a glomerulopathy or glomerular nephritis? You have to be so cautious interpreting the protein of the urine in the context of AKI. Because when you have an AKI, you will overestimate the degree of proteinuria. So even when you send a spot protein to creatinine ratio, the best time isn't when the patient has an AKI. Though if that ratio is markedly abnormal, like the patient's losing 10 grams a day, then you say, okay, now that's nephrotic range proteinuria. One other thing that was a little surprising to me is that there was any glucose at all detected on the urinalysis. And the reason that surprised me is because this patient's cachectic, has a normal serum glucose. And if you think about it, the most of the glucose gets reabsorbed in the proximal tubule, and the threshold to overwhelm the proximal tubule, you have to be like glucose north, I think, of 150. It's like whatever is less than that, the kidney should reabsorb. You shouldn't lose glucose. So it makes me pause and say, well, could this patient have a proximal renal tubulopathy? And then that would prompt me to think of other stuff that may be lost in the urine, like bicarb, amino acids, and stuff that involves the proximal tubule. But bottom line is, this patient has an AKI. There's no evidence of post-renal. There is evidence of inflammation, and inflammation can lead to ATN even without hypotension. So the kidney injury may be ATN from the underlying systemic inflammatory process. I'm just a bit irritated by the UA, but it's not enough to serve as a pivot point. I might repeat the UA just to see if there's any progression of red cells or stuff like that. And the granular cast and waxy cast, they're not very specific to a type of abnormality that may exist. And I believe you told us that the albumin was low too, the serum albumin. Again, I don't think we're losing a lot from the urine, but maybe a protein to creatinine ratio would be helpful. And this patient's inflamed, so that could be a negative acute phase reactant. But let me pass the mic to Robbie to see what his thoughts are.
Yeah, Professor, I love the authentic humility about what the UA can mean. And I think the same applies for the labs. The platelet count are slightly elevated, so that gets you worried that there might be inflammation. And it's good to take inventory of all the other organs to say the liver doesn't seem to be involved. And I'm not sure what to make of the PSA, honestly. I would probably just ignore it. I think that imaging might challenge that assessment, but I don't have any confident way of assessing the PSA or making progress with it, so I'm letting it be. And so I think you're right. I think the challenge will be, that's okay, it's all good. The challenge will be, do we apply significance to this UA or do we not? But I think the remainder of the clinical syndrome is also kind of a tease. I'm asking myself, how would I make progress in real life? And I think you're just trying to attach significance to these findings. So we see euglycemic glucosuria. Do we also have a low uric acid? What is the phosphorus like? Are those gonna, what is the bicarb like? Do we see a full-fledged Fanconi syndrome? So it's really just trying to get more data to say, is this truly like proteinuria of pathological significance? Is this a true tubular issue before we label those things? All right, tell us more, y'all. What did y'all do next?
Yeah, so I mean, this patient I met at the end of a week. So we planned to, given that his creatinine did not really change a lot from the past, we took some urine protein electrophoresis and serum protein electrophoresis, albeit they take about 1 week to get done here. The albumin creatinine index we get in a day, and that we got, and that was 18 in our units, which is about 18 grams per mole. So that's very slight microalbuminuria. Yes, and that's per day. That's an estimate per day. Yeah, this is the albumin in the urine, albumin to creatinine ratio. That's how it's reported here. Yes. So we planned to, given all these things, like everything said, the main thing we wanted to exclude was an autoimmune process or an autoinflammatory process affecting the kidneys and having affected the uvea and the pancreas at an earlier stage. So we planned him for admission for a biopsy at the beginning of the next coming week. And we planned for some imaging to take place, and that was imaging of the chest and the abdomen with the CT. And we have some pictures we wanted to show here because he did not have any appreciable adenopathy on exam. Can I share screen now? Is it possible?
Yes, go ahead. You should be able to. Let me know. Oh, there you go. Let me know if you have any trouble.
Yeah, I did. Wait. Do you see my screen here?
No, not yet.
Okay.
Okay, there we go. It's coming now.
Yeah, wait, I'll just try to. Yeah, so we had some very slight adenopathy, para-aortic, and in the axilla of about 10 to 15 millimeters in the axilla, and 6 to 8 millimeters at the level of the para-aortic region. Do you want to get more information, or?
I'll just share quickly and then pass the mic to Prof. for the next round,
Yeah,
which
sure.
is if you're in the world of autoimmune disease and you're making a shortcut to assume autoimmune is not infectious or not malignant, there are not many autoimmune diseases that feature lymphadenopathy. And there are a fair number of S's that can do it, with sarcoid and lupus, the SLE and sarcoid being the champions of the disease. But here in the here, and important in this case, would be IgG4 disease and histiocytic conditions. And I think one thing that I failed to mention is trying to find the peripheral correlate or the laboratory correlate for the atopic dermatitis. And if you see eosinophilia or an elevated IgE on the SPEP that you'll get, that might be another helpful thing to get. But autoimmune plus lymphadenopathy, not many. Think 2 S's, lupus and sarcoid. The rest are not as common, but IgG4 disease, Still's disease, histiocytic disorders, and some other ones too. Alrighty, tell us more, please.
Yeah, sure. So yeah, he got what do you call it? We got him to the renal ward to get a biopsy. Given that it takes, as said, it takes like 5 to 7 days to get the full result of the SPEP and the UPEP. And so yeah, we got a biopsy with the. Do you want us to say what our differential diagnosis was when we had this patient? We were actually thinking kind of along your lines, either sarcoid nephropathy or IgG related nephropathy, or TNU, Sjögren syndrome. Given that we're in Sweden, we have to put it there, albeit he didn't have any Zika syndrome. So that was our main differentials actually. Yeah, so the biopsy showed the following. I'll actually also share a screen because we were lucky enough to get an image from the radiology department. Is it okay if we do that? Okay. بدون تالا. Then okay. Wait. Yeah, so this is the image, and the report was that, do you want us to read what the report showed on the HE stain?
Yeah, actually, Robbie will tackle this image.
I can tell you what this image shows.
Yeah, sure.
This image shows it is an HE stain at around 10x magnification. That's all I got. Thank you. What do you think, Prof?
Robbie, let me ask you though, doesn't it look like granulomas?
You know what? I think so. Shema has more confidence than me.
Yeah. Please tell us what it shows. It's a biopsy.
Yeah, I mean, we're not that good when it comes to pathology. However, the report was that it showed interstitial inflammation. That's what we got on the telephone, and that we could get the same day. So the pathologist gave us a preliminary report of tubular interstitial inflammation, and on the basis of that, given that we'd not gotten the IgG levels, we'd not gotten the ACE levels, and we've not gotten the urinary protein electrophoresis, we started the steroids at about 0.8 milligrams per day. Yeah, the patient was kept for 1 day after the biopsy for observation, and already then we could see that his creatinine had fallen to equivalent of 2.4 milligrams per deciliter of in American units.
So it's so fascinating, Mohammed. First of all, thank you so much, Sohail and Mohammed, for bringing the images. I think it just adds so much more to the case that you're presenting. I think what's so fascinating with this case is that this patient has this kidney injury, is cachectic, and we know that the kidney injury is probably the main anchor point, because there's not much more to go after. But the interesting thing is the UA, it just was enough to irritate us, and it's difficult to interpret in the context of an AKI. But if you ask the question, what causes interstitial nephritis or tubulointerstitial, and when you damage the tubules, you're going to lose protein in the urine, but the tubules is going to help reabsorb. And I imagine you can lose some glucose too in this context. Oftentimes we'll see a little bit of white cells in the urine. You may or may not, but that's like a helpful clue. It may be totally bland, but usually you have protein. Tubular interstitial nephritis, you can think of like 3 buckets: medication exposure, antibiotics, PPIs. PPIs are a common cause, and that's why I don't like PPIs in patients who have kidney injury. NSAIDs. The second bucket is infection, and this can be the run-of-the-mill pyelonephritis, tuberculosis, other infections that can cause tubular interstitial nephritis. And then the third bucket is the autoimmune, and that is the S's again: the sarcoid, the Sjogren's, the lupus, the IgG4-related disease. Now, this is where it becomes really interesting. You shouldn't look at this patient only in the context of interstitial nephritis. This is where you bring in the pancreatitis, the lymphadenopathy, and the anterior uveitis. And when you bring in all of this, you dump out the medications that cause tubular interstitial nephritis. You can also confidently dump out the infectious causes. I promised myself that I would never say it's not TB, but you can dump that out, because every time this patient gets prednisone, they get better. So it's a prednisone responsive state. So now we're just in the autoimmune. So you ask yourself, can Sjogren cause uveitis, lymphadenopathy, and interstitial nephritis? The answer is yes. And truthfully, this is where like the ANA, the Rho, the LAW antibodies are helpful. Can sarcoid cause pancreatitis, uveitis, lymphadenopathy, and yes, the answer is yes. And sarcoid is a very tricky diagnosis because it's one of exclusion. It's one of exclusion. And then the question becomes, can IgG4-related disease do all of these findings? And Robbie taught us it could also explain the skin. And the answer is yes. And IgG4-related disease is probably the much better hit for the pancreas than the other ones. So it's a I like the kidney biopsy, but I feel like I need more data. If the serology doesn't point to Sjogren's or lupus, then I would love to go after the axillary lymph node to see, am I getting lymphoplasmacytic infiltrations or am I getting granulomas? And I think that'll be key. But you might then argue and say, well, if it's IgG4 or sarcoid, aren't we just going to give steroids? And the answer is yeah. I don't know how it changes long-term management, but if it does, and if it's important to make that distinction, I think that axillary lymph node is a very safe site to go and do a biopsy and see if there's granulomas or findings of lymphoplasmacytic infiltration.
Yeah. Do you want more information, maybe?
Please.
Yeah, so we started getting some labs during that week, and his autoimmune panel, including ANA, extractable nuclear antigens, ANCAs, anti-ROS, anti-LAS, all of them were negative. His serum protein electrophoresis showed a IgG level of 21.4 grams per liter. Given that they were going to analyze the subclasses which would come the next day, the urine protein electrophoresis showed kappa and lambda chains. In our units, it's 119 and 51, but the ratio between kappa and lambda was normal. It was under 4. And we also got a serum ACE level, which was normal, along with the complement functions, which were within normal limits. However, he had an elevated C3D as the only marker of complement activation. So yeah, that's what we got currently. I said the subclassification of the IgGs was still undergoing.
Fascinating case. I just say that I think the tests that we're all getting are very, very good, and some of them are better than others. So seronegative Sjogren's exists, but it's much less common than you'd think. And so I think that we'd certainly made it less likely. The serum protein electrophoresis helps us rule out a monoclonal process, since the kappa and lambda are made an equal ratio, excuse me. It is actually a little bit surprising that the complements are normal, because if you're invoking IgG4 disease, waiting for the IgG4 level to come back, most patients who have tubular interstitial nephritis from IgG4 disease actually have low complements. So that's an interesting twist in the story. I'm not sure, Mohammed and Sohail, if you have the IgE level on the serum protein electrophoresis.
Yeah, in Sweden, that is something that's usually ordered separate, and it was
Oh.
not available for this specific case, actually.
Okay.
But we did get, maybe the most important detail was that we got the IgG4 levels a day later. Is that interesting?
Yeah, of course.
Yeah, and that was at 3.42 grams per liter. So that was 3 times upper limit of normal, approximately.
Prof.
Does
Ed,
that-
what do you think?
You go for it, my friend.
No, I would just say that you have to be careful with this test. It is a very, the problem with calling it IgG4 related disease is this overemphasis on the IgG4 level. And I would just tell you that while this case is a great case for IgG4 disease, the test alone is not great. It has a sensitivity and specificity of no more than 80% both. So here, the only reason that I would be suspicious of IgG4 disease is not the IgG4 level. It just confirms that this is a hypothesis we should chase. So how is IgG4 related disease diagnosed? It's histopathology, it's tissue, and it's exactly what Prof. Rez said. You have to either get more tissue or reanalyze the tissue for the 4 cardinal features of IgG4 disease. Is there IgG4 plasma cells? Is there eosinophilia? Is there fibrosis in a very specific pattern called storiform fibrosis? And then finally, is there evidence of venulitis or inflammation around the veins? That's how you diagnose IgG4 disease. So this test is great. It gives you, it's a simple way of remembering the disease, but don't attach too much to it. IgG4 disease, is just like sarcoid, is a biopsy-based diagnosis. And all I will say is just listen to Prof. Rez's discussion earlier about the importance of tissue. And this test is a great test to help you remember the disease, but I think it gives us too much attachment to the test. What do you think, Prof. Rez? How do you take this?
I love that. I absolutely love it. And it'll be really interesting. And I'm curious to know what Mohammed and Sohail did with this data.
Yeah, so we actually called the pathologist and requested IgG4, what do you call them? Yeah, staining for the IgG4 levels and for the CD3, CD4 cells and eosinophils. And they said that it would take about 3-4 days for them to start getting them. But hello?
Yeah, go ahead.
Yeah. So when the pathologist called us later, and he gave us this picture. I don't know if you guys. I'll just try to share screen because this is interesting. Yeah. So do you see my screen here?
Yes, let me read it. This is a 10x magnification, and it shows IgG4 cell staining.
Yes, indeed.
Yeah.
That's what it shows. And the stain does show findings that are unequivocally in line with IgG4 related disorder of the kidney, so-called IgG4 tubular interstitial nephritis. The pathologist reports 20 to 30 IgG4 positive plasma cells per 40 cells in a high power field, along with increased eosinophils when they looked for them. There was not very severe storiform fibrosis in the pathology specimen. Do you guys want to know more information?
Yeah, I think at this point, Mohammed, it's pretty convincing that you have your diagnosis of IgG4 related disease. And truthfully, it would be hard to make, like, most cases of pancreatitis are not due to IgG4 related disease, and you'd be wasting your time sending. The only 3 tests you should do in pancreatitis is an abdominal ultrasound looking for a stone, calcium levels, looking for hypercalcemia, and triglycerides. You should not be sending SPEPs and IgG4 levels in acute pancreatitis. But once you add the layer of anterior uveitis, my friend, then you should start thinking of this. And then you add the kidney injury. Now it's time to go, running towards this diagnosis. But I think the main takeaway, for me at least, is that when patients present with one problem at a time, it's easy to misdiagnose their next presentation. You have to almost step back and connect the dots that are occurring at separate time periods. So someone like this, it's so easy to have said, oh, pancreatitis, discharge, uveitis, discharge, interstitial nephritis, discharge. But once you step back, you're like, how can it be anything other than IgG4 related disease? So I think it's really, really powerful.
And
yeah,
we have actually another detail, the PSA. It was interesting, given that the PSA was elevated at presentation. We took it about 2 weeks after prednisone, and it had fallen down to almost normal levels. In our units, it's about 3.5. So he's under evaluation at the urology department for IgG4 related disorder of the prostate as well.
That's incredible. I totally forgot the PSA, but
Yeah.
Unbelievable explanation of that.
We put it there in the beginning, kind of to make it is it called a red herring in English, maybe? Yeah.
Your English is better than mine, Mohammed. I know we're almost at time, but I don't know. I feel like this was a very special session. I think this is the first time we've had 2 new friends from Sweden joining us. And I think that your passion for medicine is so evident and obvious here, as is the strength of your knowledge and reasoning. It is a delight to have shared this stage with you. And I really, really hope that we see you very, very regularly on VMR in the future. I think you clearly are CP solvers in your heart and core. So thank you so much for coming and presenting this case. Maybe before we pass the mic to Deborah, can you share with us what this journey was like for you and what your big teaching points are?
No, actually, the main teaching point was that even if the presentations come at different time points, they have to kind of be connected together. So that was actually the main teaching point. And as you mentioned, Rabbi, the fact that an IgG4 level was normal at the first presentation does not exclude it being a IgG4 related disorder. So yeah, think of IgG4 disorder one more time than less.
I absolutely love that. My biggest takeaway is problem discharge, send it to Prof. Rez and he will discharge the diagnosis right away. Prof. Rez, that was such a cool takeaway. I never thought about it that way. How you how we talk, I'll say it this way. We talk about, I think in cognitive bias literature, people talk about diagnostic momentum as like a bad thing, where you're like, have too much momentum towards a bad diagnosis. But I think you just made me realize how diagnostic momentum is so important sometimes. And when you break up the case, it loses momentum. So people stop thinking about it. And how if this patient had presented with all these things at one time, you might have had much more momentum to make the diagnosis like we had the chance here. Really cool observation. All right, Deborah, take it home.
Thank you for the case. Thank you for the discussion, Roy and Reza. I'll go for some quick teaching points. So we thought that it was a 32-year-old male, that it's a young person, and if it's coming for the hospital, we should really think that it's something happening. And then Reza said that we can think about the sex, drugs, and rock and roll, but we can think about something genetic too. And the pancreatitis, we can put in 2 categories. It could be some substance, for example, medication, alcohol, or an obstruction like stones, mass, pancreatic stone. And in the uveitis, we think that is something unusual that we could think about it in this past medical history of pancreatitis, uveitis, and kidney injury. And thinking about the causes of uveitis, we can think about this chat. Anterior, we can think something about autoimmune, like lupus, Sjogren, inflammatory bowel disease. And posterior, we can think about something viral. And then Reza said that a lot of patients with acute pancreatitis can have diabetes. And then I looked for it, I put in the chat paper and had like a lot of conditions that make that happen, like the loss of islet cell mass and autoimmune induction. The two pathologies can have the same risk factors, can be a systemic inflammation, and the last can be like an alteration of the insulin in the pancreas. So that could be the explanation for a patient with acute pancreatitis has a complication as diabetes. And Professor West told us about the interstitial nephritis that we can put in 3 categories: medications like antibiotics, PPI, infections, TB, pyelonephritis, and autoimmune sarcoidosis, Sjogren, lupus, IgG4. And to finish, Robbie said that the disease IgG4 is not specific for when we order in the serum, but it is a biopsy that we need like tissue pathology to make the diagnosis, just like sarcoidosis, and we need like IgG4 plasma cell fibrosis, venulitis, and eosinophils. And the case presenter gave us a pearl that even that the presentation can happen in different times, we can be relate all of them in the same disease. So yeah, thank you everyone for this case, this section, and I want to invite everyone for tomorrow. We are going to have our match celebration at 1 p.m. and we are going to have a management reasoning at 2 p.m. AST. So yeah, thank you everyone.
Deborah, that was incredible. I love the additional pathophysiology that you taught. Thanks for taking the teaching to the next level, my friend.
Thank you.
Bye, everyone.
Bye.